The COVID-19 pandemic has exposed gaps in our global pandemic preparedness and given us the opportunity to address these when working to prevent the next pandemic. The World Health Organization Global Action Plan has identified 7 key action points that will contribute to a better, more equitable global health ecosystem. Our team recommendations will be based on these and the United Nations Sustainable Development Goals. At the broadest level in pandemic prevention is climate change and the destruction of ecosystems. These are causes of zoonoses and transmission of new pathogens. Humans coming into contact with these vectors will be at increased risk for new infectious diseases and potential pandemics, as can be seen in the disease patterns over the past 30 years. At inequitable risk from both climate change and pandemics are our most vulnerable populations. To prevent the next pandemic, we must invest in transnational climate change research. Climate change and health should be compulsory in the curricula of all health discipline students, and our workforce must be trained to advocate against climate change and its effects.
During the COVID-19 pandemic, countries who were unprepared and had to redirect resources towards meeting the demands of health systems had put certain communities at risk. In Italy, a coherent strategy by public health authorities was absent due to the highly fragmented healthcare system. Some hospitals in Lombardy applied existing plans for responding to maxi emergencies, but these plans were designed to manage short-term natural disasters and not viral pandemics. In the US, the obvious disconnect between the public health and healthcare delivery put the safety and well-being of vulnerable populations at risk as they struggle to gain access to equitable care while maintaining economic and social stability. In Armenia, the MOH and government strategized their responses. Designated hospitals were renovated, furnished, and equipped with necessary infrastructures and medications to accept only COVID-19 patients regardless of ethnicity or social status. Therefore, we recommend countries to fortify national preparedness plans and invest in public health services, urging health systems to establish detailed plans on diverting capacity to pandemic management while maintaining essential services. Being inspired by Armenia and the US, task force dedicated to strategizing and coordinating preventive measures against pandemic prevention should be established.
The third recommendation is to expand the health workforce. During the pandemic, we can see the arduous situation of a staffing shortage. Because of that, some developed countries may use their capital to hire travel nurses, as staff nurses make around 1 for all a week, while travel nurses make between 5,000 to 20,000 a week during the pandemic, which further damage other countries' health system and harm health equity. Because of that, we suggest that we should increase the salary of the healthcare workers to show recognition for the work of health professionals and improve medical education program to enhance the professional competence of staff and strengthen their sense of belonging to the health system and provide smart health infrastructure and better support systems such as AI models for psychological support.
Lack of education makes it difficult for people to have a sense of personal control over their lives and health. It is estimated that about 80 million adults in the US have limited to low health literacy. We can promote public health education through communication by raising awareness about healthy behavior through newsletters, health fairs, and mass media campaigns. We can also motivate change in behavior and actions through knowledge by offering free short courses, training, and support groups to people who cannot afford health literacy.
There is also a clear inequity in healthcare access between population groups, those with different sexual orientation, ethnicity, race, gender, etc. Several studies found that the majority of healthcare systems fall short in having a workforce that represents the population it's serving. These studies found strong links to development of trust issues with healthcare providers, which not only means hesitancy utilizing services, but also reduced adherence to interventions. This was demonstrated by the lower vaccination rates of minority groups in those countries during the COVID-19 pandemic. It's crucial we address this issue as patients who identify differently to healthcare providers they're interacting with would feel less comfortable and therefore less likely to establish a good relationship, which we know is an essential component to better health outcomes. Training a more diverse workforce will involve reviewing the population demographic, finding groups with low representation, then catering promotional strategies to attract people from those groups to healthcare professions. In New Zealand, this is achieved through the MAPAS program to increase representation of Māori and Pacific populations in the health workforce. This will improve the relationship that the population has with the healthcare system and therefore improve compliance with interventions such as vaccines and guidelines like lockdowns, which may be introduced in future pandemics. This also ultimately reduces minority inequities we face in healthcare outside of pandemic settings.